Carpal tunnel syndrome, often abbreviated as CTS, is the most common peripheral nerve entrapment disorder. Affecting about 1 in 10 people during their lifetime, CTS is caused by compression of the median nerve as it passes through the narrow carpal tunnel in the wrist. This compression leads to symptoms like pain, numbness, tingling, and weakness in the hand, especially in the thumb, index, and middle fingers. The condition can significantly impact daily activities and overall quality of life. Understanding CTS is crucial for both patients and healthcare professionals, as early recognition and proper management can prevent long-term complications and restore hand function. Carpal tunnel is a narrow passageway located at the base of the palm, bordered by carpal bones and covered by the transverse carpal ligament. Inside this tunnel, the median nerve travels alongside the flexor tendons that control finger and thumb movement. Because the tunnel is rigid and confined, any swelling or inflammation can quickly compress the median nerve, leading to the classic symptoms of CTS. Understanding this anatomy helps explain why certain movements or repetitive activities can aggravate the condition and why targeted treatments are necessary for relief. Early symptoms of carpal tunnel syndrome often include tingling, numbness, and pain in the hand, especially at night. These symptoms may radiate up the forearm and are frequently aggravated by repetitive hand movements or sustained wrist positions. Recognizing these signs early is essential because prompt intervention can prevent progression to more severe nerve damage. Patients may also notice weakness in grip strength or difficulty performing fine motor tasks. Early recognition not only improves outcomes but also opens up more treatment options, including conservative approaches. History of carpal tunnel syndrome dates back to the mid-19th century, but it wasn't until the 20th century that CTS was recognized as a distinct clinical entity. Early cases were often misdiagnosed as arthritis or other nerve disorders. As medical understanding advanced, clinicians began to associate the characteristic hand symptoms with median nerve compression at the wrist. This recognition paved the way for targeted treatment strategies and a better understanding of the underlying pathophysiology, setting the stage for future advancements. Initial approaches to treating CTS were conservative and focused on symptom relief. Patients were often advised to rest the affected hand and immobilize the wrist using splints. These splints kept the wrist in a neutral position, reducing pressure on the median nerve, especially during sleep when symptoms often worsened. Heat or cold therapy was also used to alleviate discomfort. While these methods provided temporary relief, they did not address the underlying cause of nerve compression, and many patients eventually required more definitive interventions. Dr. George S. Phelan played a pivotal role in defining carpal tunnel syndrome as a specific diagnosis in the mid-20th century. His research and clinical observations led to the development of the Phelan test, physical exam maneuver still used today to diagnose CTS. By linking characteristic symptoms to median nerve compression, Dr. Phelan's work established a foundation for targeted treatments and increased awareness of the condition among both clinicians and the public. Introduction of open carpal tunnel release surgery marked a turning point in CTS management. This procedure involves making a 3-5 cm incision in the palm to directly visualize and divide the transverse carpal ligament, relieving pressure on the median nerve. Open release quickly became the gold standard for moderate to severe cases, offering high success rates and significant symptom improvement. However, the larger incision led to longer recovery times and more postoperative discomfort compared to newer techniques. Reduce tissue trauma and speed up recovery, surgeons developed the mini-open carpal tunnel release. This technique uses a smaller incision, typically 1.52 cm, allowing for direct visualization and division of the ligament with less disruption to surrounding tissues. The mini-open approach balances the benefits of open surgery with the advantages of minimally invasive procedures, offering faster return to daily activities and high patient satisfaction while maintaining effective symptom relief. Endoscopic carpal tunnel release represents a major advancement in minimally invasive surgery. Using 1 or 2 tiny incisions, surgeons insert a camera and specialized instruments to cut the transverse carpal ligament from beneath, minimizing tissue disruption. This approach often results in less postoperative pain, smaller scars, and a quicker return to normal activities. However, it requires specialized training and carries a learning curve, with careful attention needed to avoid nerve injury. Numerous studies have compared open, mini-open, and endoscopic carpal tunnel release techniques. While endoscopic surgery offers faster short-term recovery and less scar sensitivity, long-term outcomes are similar across all methods when performed correctly. The choice of technique often depends on surgeon expertise, patient anatomy, and individual preferences. Regardless of the approach, complete division of the transverse ligament is essential for successful decompression of the median nerve. Splinting remains a foundational non-surgical treatment for CTS, especially in mild or early-stage cases. By keeping the wrist in a neutral position, splints reduce pressure on the median nerve and are most effective when worn at night. Patient education on proper splint use is crucial for maximizing benefits. While splinting can provide significant symptom relief, especially for nocturnal symptoms, it may not be sufficient for more advanced cases. Corticosteroid injections are a popular conservative treatment for CTS, providing temporary relief by reducing inflammation around the median nerve. These injections can be performed quickly in an outpatient setting and are especially useful for patients who are not immediate surgical candidates. The effects may last from weeks to several months, and ultrasound guidance is increasingly used to improve accuracy and safety. However, repeated injections have limitations due to potential side effects. Physical therapy plays a vital role in CTS management, particularly for those seeking to avoid or delay surgery. Therapists use manual techniques, nerve gliding exercises, and targeted strengthening to improve wrist and hand function. Ergonomic modifications such as adjusting workstations or tool use help reduce strain on the wrist. These interventions empower patients to manage their symptoms and can provide moderate improvement, especially in mild to moderate cases. Today's conservative management of CTS integrates splinting, NSAIDs, corticosteroid injections, and physical therapy. Each modality offers unique benefits: splinting for immobilization, NSAIDs for pain relief, injections for inflammation, and therapy for functional improvement. These treatments are often combined for a synergistic effect, tailored to the severity of symptoms and patient preferences. While effective for many, they may not provide permanent relief if nerve compression is significant. Therapeutic ultrasound is an emerging modality for CTS, using high-frequency sound waves to promote tissue healing and reduce inflammation. High-resolution ultrasound imaging is also revolutionizing diagnosis, allowing clinicians to visualize the median nerve and assess dynamic changes during wrist movement. These advances are making diagnosis more comfortable and accessible, and may soon become standard adjuncts to clinical examination. Innovative treatments like platelet-rich plasma, PRP, and stem cell injections are being explored for their potential to reduce inflammation and promote nerve healing in CTS. While still experimental, these regenerative therapies offer hope for patients with chronic or severe cases, especially when traditional treatments are insufficient. Ongoing research aims to determine their effectiveness and safety in restoring nerve function. Neuromobilization techniques, including advanced nerve gliding exercises, are gaining popularity as adjuncts to physical therapy. These exercises aim to improve the mobility of the median nerve within the carpal tunnel, reducing adhesions and enhancing functional outcomes. When combined with standard therapy, neuromobilization can provide additional symptom relief for patients with persistent or residual symptoms. Advances in technology are shaping both the diagnosis and treatment of CTS. High-frequency ultrasound, ergonomic splints, and improved surgical instruments are making procedures safer and more effective. Robotic-assisted surgery and personalized medicine approaches are on the horizon, promising even greater precision and tailored care for patients. These innovations reflect a broader trend toward integrating technology with traditional therapy. Deciding between surgical and non-surgical treatments, several factors are considered: symptom severity, duration, nerve impairment, and patient preferences. Surgery is generally reserved for moderate to severe cases or when conservative measures fail. Non-surgical treatments are effective for mild cases and can delay or prevent the need for surgery. The best outcomes are achieved when treatment is matched to the patient's specific condition and needs. Long-term studies show that surgical intervention provides more definitive and lasting relief for moderate to severe CTS, while conservative treatments are best for mild cases. Recurrence of symptoms can occur, particularly if the initial surgery was incomplete or if underlying conditions persist. Regular follow-up and appropriate patient selection are key to maintaining good outcomes and minimizing the risk of recurrence. Effective CTS treatment not only relieves symptoms, but also restores hand function and improves quality of life. Surgical patients often report dramatic improvements, especially in severe cases, while those managed conservatively appreciate the non-invasive approach. Shared decision-making between patients and providers ensures that treatment aligns with individual goals and expectations, leading to higher satisfaction and better overall outcomes. While carpal tunnel surgery is generally safe, complications can occur. These include infection, nerve injury, hematoma formation, and scar tenderness. Most complications are rare and manageable with proper surgical technique, sterile protocols, and attentive postoperative care. Surgeons take proactive measures to minimize risks, and patients are educated on signs to watch for during recovery. Non-surgical treatments are generally low risk but not without potential side effects. Corticosteroid injections can cause local pain or tissue changes, while prolonged splint use may lead to stiffness or muscle weakness. Overly aggressive physical therapy can worsen symptoms if not properly supervised. Patient education and regular monitoring help prevent and address these issues, ensuring safe and effective conservative management. Prevention of complications in CTS management relies on meticulous surgical technique, careful patient selection, and thorough education. Surgeons use precise methods to avoid nerve injury and infection, while patients are guided on proper splint use and exercise routines. Regular follow-up appointments allow for early detection and management of any emerging issues, ensuring a smooth recovery and optimal outcomes. Over the past century, CTS management has evolved from simple rest and splinting to sophisticated surgical and non-surgical interventions. Advances in medical knowledge, technology, and patient-centered care have expanded the range of available treatments. Today, clinicians can tailor therapy to each patient's needs, balancing effectiveness, safety, and personal preferences for the best possible outcome. Looking ahead, ongoing research and innovation promise to further improve CTS management. Minimally invasive surgical techniques, advanced imaging, and regenerative therapies are at the forefront of development. Personalized medicine approaches, including genetic and molecular research, may one day allow for earlier diagnosis and targeted prevention strategies. The future of CTS care is focused on maximizing recovery while minimizing invasiveness and risk. Best practices for CTS emphasize evidence-based, patient-centered care. Mild to moderate cases are managed conservatively with splinting, therapy, and injections, while severe or unresponsive cases are referred for surgical release. Early diagnosis and intervention are crucial for preventing permanent nerve damage. Clinicians work closely with patients to select the least invasive yet effective treatment, ensuring optimal functional recovery. There are several areas where further research could transform CTS management. Large-scale studies comparing treatments, biomechanical research into risk factors, and investigations into predictors of treatment success are all needed. Regenerative and biologic therapies as well as novel medications represent exciting frontiers. Collaborative research and data sharing will accelerate progress and help establish new standards of care. Powering patients through education and shared decision-making is a cornerstone of modern CTS management. By understanding their condition and treatment options, patients can actively participate in their care, leading to better adherence, satisfaction, and outcomes. Clinicians provide guidance, but the patient's values and lifestyle play a central role in choosing the right path forward. Carpal tunnel syndrome remains a common and impactful condition, but the evolution of its management offers hope for improved outcomes. By combining established treatments with emerging therapies and a focus on individualized care, healthcare providers can help patients regain hand function and quality of life. Ongoing research, innovation, and patient engagement will continue to drive progress in CTS care for years to come.